Okay, good morning, everyone. And all of you that know me know I don't like microphones, so bear with me. And I want to say welcome to our Sarcoidosis Educational Town Hall and the Caring Hands Sarcoidosis Foundation. Thanks you so much for coming out. Of course, I wrote notes, but I can't see and talk at the same time too. So anyway, we just appreciate you coming out. We appreciate you registering. Now, just to give you a little background about Caring Hands Sarcoidosis Foundation, it was founded in 2009 by me after I had to go on disability because of sarcoidosis. So our mission is patient advocacy, education, self-empowerment for those suffering and managing their life with sarcoidosis. So I want to thank our panelists. Thank you so much for volunteering your time and your expertise for coming out. So I'm going to invite you up on the stage, and then we're going to just talk a little bit more about this beautiful big blue folder that I have. So right now, and I have your seats. So on the first chair will be Dr. Medici. Thank you. And I'll have Renee sit here. Dr. Kolfa, Heather Witt, Dr. Nair, Dr. Enrique, and Dr. Bowles. So I hope that you're not too squished. I put two tables together, so the divider is right here in the middle. So I have these bags on the table, and those are just tokens of thank yous from us. Yeah, Dr. Nick, right next to you. And on the list, your name is at the bottom of the bag. Now, each of you were given a card when you came. Each of you were given a card when you came to the registration table. They were given to you to write a question down for our panelists. If you need an ink pen, there's some up on the table. We can get that for you. Now, they'll be collected shortly, so make sure you have them written down so we can collect them. You didn't get a card? Kristen, can you bring some of those cards down here, please? And does anyone need an ink pen, or do you have one? I have an ink pen. Okay. Christopher's coming down. Okay, thank you so much for that. Thank you, Christopher, for bringing those down. So we'll just give you a few moments and we'll collect them by the time our panelists get done introducing themselves. So right now, I'll pass the mic down for our first panelist, and each of them are going to tell you a little bit about themselves and whatever else they want to share with you regarding their specialty.
Hello, everybody. My name is Dr. Anna Marandici. I'm a clinical cardiologist in the Australian Women's Heart Center in Royal Oak, Beaumont here. And I really enjoy doing patient education outside of my regular practice because I think it's a very direct way of reaching people that I might not otherwise meet. I actually see sarcoidosis patients more so as referrals from pulmonologists. As many of you know, sarcoidosis can also involve the heart. And it is thought that about 25 to 50% of sarcoidosis patients have subclinical or asymptomatic heart disease. And it's mostly that of the cardiac muscle as opposed to the arteries of the heart. But about 5% of patients do have clinical symptoms of heart disease from sarcoid. Does anyone here have cardiac sarcoidosis that you want to share? Okay. All right. So that's kind of representative, as a slice of the population, too, of, how many ever we have in the room. But it is important to have a diagnosis of cardiac sarcoidosis. Usually the symptoms are palpitations or shortness of breath, kind of non-specific because it's the electrical system of the heart that first gives its first message that there's something going on in the heart muscle. And nowadays there are many ways to screen for cardiac sarcoidosis outside of just an EKG. History is very important, when patients actually develop symptoms. But the cardiac MRI is one that can show us actual involvement of sarcoidosis into the heart muscle. So I do encourage people with sarcoidosis to pay attention to their hearts, and as a general rule, kind of always have a cardioprotective lifestyle and diet, because that which is anti-inflammatory is good not just for the heart but also for every body system, especially when one has kind of an autoimmune type of disorder or otherwise. So I hope that none of you ever have to see a cardiologist for treatment of cardiac sarcoid, but do be aware that it is a potential complication. Thank you.
My name is Renee Kita, and I'm a respiratory therapist here in the Beaumont Hospital organization. And I just want to say I'm representing all of the respiratory therapists that work in the pulmonary rehab team. We're happy that you're here. We're happy that you're getting to the bottom of information gathering and trying to be proactive in your disease process. I would encourage all of you to speak to your pulmonary doctor or your primary care doctor and see if pulmonary rehab just isn't something that is a good endeavor for you. Once you're in the pulmonary rehab program, which requires a physician order and a pulmonary function test, which is a breathing test. It can be as simple as the simple spirometry that the doctors will do sometimes in a primary care setting, but it also can involve the more elaborate PFT where you're actually in like a clear body box. But any which way, if you have an order for your doctor to come into pulmonary rehab and you have the PFT, we can bring you on in. We pre-clear it based on your pulmonary function results, what the insurance, if you meet the guidelines. There are special programs throughout the Beaumont hospital system so that if you don't in particularly meet the insurance standards, we still have a way to bring you in. And I'm very proud to be part of that rehab team because we really do excellent work. We see so many patients in a debilitated position, because when you're having difficulty breathing, what do we all do? Our mind says, well, we need to sit, we need to rest, we need to, take a minute, and sometimes that minute becomes an hour, and then you get absorbed in a TV show, or, like, little by little, our experience is that patients will, find themselves sitting, and when that happens, that's muscle wasting, that's the fancy medical term for that is muscle decompensation. But the good news is that when you come into the program, you are medically monitored for oxygen levels, blood pressure, heart rate. We coach you for breathing techniques, and we get you working, plain and simple. But and it is a little bit of a push and a little bit of a nudge, but we have seen some really fantastic outcomes at our rehabs. And why can't that be all of you? If you find that you're short of breath walking up the stairs, tucking a sheet, vacuuming, those are very common issues that we see, just regular household activities. When a muscle is not toned up, it requires more oxygen to do the same work. And it's a very slow and steady decline that we see. It's not lightning bolt fashion where, oh, now you just can't do that activity, that you could do you can't walk the trails with your grandkids, but you could do it the day before. It's not like that. It's just a slow, steady deterioration of the muscles, and we can help you with that, and we would love to do that, and that is what we do in the pulmonary rehab. So there is at the back table information for you to come into the pulmonary rehab program. There's a brochure, and there is also there's a physician order form that you could simply take to your doctor and have them fill that out for you. And we would encourage you to please talk to your doctor if that is a viable option for you. But I just see, when I look out into this room, I see all the people we could help. That's what I see. I see that we could get people into a much better spot for their breathing, their, just enjoying life better. So go for it and pick up our seat back there.
Hi, my name is Dr. Kofa Joatopi-Slusser, but most people just call me either Dr. K or Dr. Kofa. My story was featured on Botched this season. It aired in February 14th or 13th of this year. I'm here because I live with sarcoidosis and a few other diseases that have affected me, and mostly it affected my face, and that's why they told my story on Botched. So if any of you saw the episode, you saw that this is not my face, this is all fillers. So, I was very grateful to have them help me. There were a lot of things that happened to me over the years where my face was swollen first, and then it was hard. And then as the hardness went away, I had so many biopsies and so on. They still were trying to figure out what was going on. Now I'm sitting here with a lot of specialists that work with patients with sarcoidosis, but where I am from in California, I'm not sure if a lot of the physicians, experienced and saw that, a lot of people live with this. And so because I wasn't presenting it in my lungs or in other areas, it was kind of a question mark for 10 years. So over time, I lost all of the fat that was in my face. And so it did affect me with different things, with employment opportunities. I'm very skilled with creative work that I do. So I still have been able to work because I'm a go-getter, but it has, been an issue. So the physicians on Botched, when they took my story in, I also had breast augmentation at one point, and my body, when I got really sick, my immune system was acting really out of control, and so the breast implants became a problem. So the doctors helped me out. They took care of that, and they also rebuilt my face using Sculptra and Restylane. So I'm very thankful. I still talk to the doctors on Botched, and my sister was very instrumental in really helping with my diagnosis. Right when she became a physician, and she was just finishing up medical school, I became very ill. Like, I had lost a lot of weight. I was in bed, I couldn't move around, and she came back from medical school, and with her knowledge, just getting out, you know, she was able to have her doctors speak. You know, like, you guys have your lingo and stuff that I can't really do because, you know, my doctorate's in education. So she was very instrumental with, you know, talking to her instructors and just different things that she saw, and it was really helpful. So I'm glad to be in the state that I am. I was not able to do a lot of different things. I was very weak all the time, but just over the years, things have gotten better, and very grateful for the team at Botched that helped me with the exterior part of feeling good, even though today I feel pretty good with diet and exercise. So I'm glad to be here.
Hi there, my name is Heather Witt. I'm the interstitial lung disease nurse for both Dr. Nair and Dr. Calvo here at Royal Oak, Beaumont. I've been a nurse for 21 years, and I'm just so glad that all of you have made it today to come and get more information, maybe feel more comfortable with the diagnosis of sarcoidosis, and maybe you can spread that out into the community to other people who weren't aware of this today, and get connected with Allison, because she is a true cheerleader to help lead patients finding more education and finding a comfort of knowing that you're not doing this alone. So thank you so much for everybody that came.
That was quick. So I'm Girish Nair. I'm one of the pulmonologists, and I'm the director for ILD program here. I work very closely with Dr. Calvo and Dr. Marindici, and I'm blessed to have a lot of Dr. Ball's patients come and see me now. But thank you first to Caring Hands Foundation and Allison and Seven Clouds Marketing for making this happen. This is such a big endeavor, and it's such that a lot of people are looking forward to it, and I think this is a great first step in that direction. I believe most of the people here do have or have some family member with sarcoidosis. It's not a new disease. It's been there for almost like since it was first reported by a dermatologist, in fact, by name Hutchison, and that was way back in 1850s. Even though it has been there since then, still we don't know much about the disease process and why some people get it, why some others don't, what is the exact etiology behind the disease. And that makes it very unique. Like, a lot of people don't know, they don't have like a classic symptom like high blood pressure or that, or my blood sugar is high. It doesn't go in like that. Most patients come in with like simple symptoms like fatigue, or something that popped up on an x-ray or a CAT scan that their doctors ordered for something else. And then they have to walk through that process. So it's very important, especially in this setting, that we listen very carefully to what the patient has to say, and understand their symptomatology and direct our care pertaining to what the patient has to say, and look in that direction. As sarcoidosis, it's kind of like your immune system goes into overdrive and forms this kind of like small granulomas or small masses, and it affects almost all parts of the body, not just the lungs. Even though majority, 90% of patients do have a disease in the lungs, it can affect the eyes, it can affect the heart, it can affect the brains, it can affect the kidneys, it can affect skin very commonly. And Dr. Marindici was mentioning, like, even though the percentage of patients who have cardiac sarcoidosis is reportedly low, there are studies with postmortem studies from Japan and so that showed like a lot of patients go undetected who have some sort of cardiac sarcoid. Fortunately, not every patient with sarcoid do progress. At least 1/3 of patients, they tend to have some sort of like symptom resolution after a few years. But some do progress, and some patients would need treatment. So it's important that we encourage and empower our patient to diagnose and identify who would need treatment, and that's a process in itself. So we need to like have them tell us a story. If there might be other things that might look like sarcoid, but that not all your symptoms could be explained by sarcoid. Fatigue, for that instance. So we encourage patients to tell us, like when we see them in our clinic, to give us a very elaborate history, find out what exactly is going on, what is affecting their day-to-day life. Is it the cough? Is it the trouble breathing? Is it something else that's going on? Is it fatigue? Is it low-grade fever? Because symptomatology is so vague. Then, based on those symptoms, then we decide if they need some sort of advanced imaging other than chest X-ray or breathing test. Some people, despite having done all that, the test all comes back negative, and we might still, if this clinical suspicion is high, we might have to do a biopsy of either the skin or the lung or the lymph nodes. Then it may not be that apparent, and there are advanced technologies now to even detect cardiac sarcoid with PET scans and MRI that can help delineate the disease. End of the day, once you have the diagnosis, then the question should be start treatment and what would need treatment. So when you go up to the doctor, what I would encourage you to do is to ask them, hey doc, what are the sites where my sarcoidosis has affected me? How many organs has it involved? What are the treatment options that are available there? And of those treatment options, which is the best treatment for me? Knowing the side effects of some of the drugs and some of the medications. And what else should I do? Are there other comorbid conditions which are there, which we need to treat? If at all, like sleep apnea, very commonly present in patients. Diabetes, if you're taking steroids for a long period of time, a lot of patients are put on steroid-sparing agents like methotrexate that can cause in itself other side effects from the medication. So if and when there are new symptoms that pop up, you will have to ask yourself, is it from sarcoid, or is it from the drug that I'm taking, or is it some infection that I have come across because of the medication that I'm taking? And then you have to go through the process of elimination and find out. So it has to be a partnership that we build between the patient and the physician that actually facilitates their care. And that's what we strive for, and that's what we are here for. And I encourage, and I'm very happy to say that we empower our patients to make those decisions for themselves and seek more questions. And that's the whole purpose of this panel too, is to try and answer as much of your questions as possible. With that, I'll hand over to Dr. Cowell.
Thank you. Good afternoon. I want to start by thanking Caring Hands Foundation for inviting me. I pretty appreciate the honor to be in front of this audience. I developed my expertise in sarcoidosis, I guess by chance. My first job out of training was in Norfolk, Virginia, and as Detroit, it has a very high frequency of patients with sarcoidosis, and it just became my passion to take care of patients with sarcoidosis. I think it's a condition that is very variable. Not two patients present the same to our clinic, and not two patients respond the same to treatment, in making it always a challenging situation. I believe that taking care of patients with sarcoidosis starts by having the patient have the most information available for them to be able to take the best decisions in terms of management. It's a condition that can be pretty benign, or it can be, and it can range to be a condition that very fast can affect many organs and not respond to treatment. blessed that I just started working with Dr. Nair, and I used to work with a legend here on my left side, Dr. Bowles. I have been blessed in the sense that I have been always around people with experience, and I'm comfortable now taking care of patients with sarcoidosis, knowing that everybody that comes to clinic has a different perspective and a different goal. So, as Dr. Nair said before, every time you come to the office, every time that you visit a provider, try to understand the best why things are happening, what options do you have, and you are always in control of the management of your condition. With no more, I'll pass it to Dr. Ball.
Thank you very much. How's everybody doing out there? Good. I was going to say that since this is a church, why is everybody sitting in the back? Backsliders. I thank Allison for having me on this program. I'm not sure why, but I'm now retired. I retired November 2nd November last year. But I'm still I still look at sarcoid because when I first started taking care of patients with sarcoid, as a pulmonologist, you're going to run into a lot of patients with sarcoid. But I wasn't the pulmonologist at Henry Ford or anyplace else that took care of a lot of sarcoid. That guy was sitting in the office next door to me, Dr. Mike Iaduzzi, who had done a lot of research and everything like that, but he left a system. So I was called into the chief's office, say, we want you to take over the sarcoid clinic. Well, Mike, you see, I like general pulmonary. I'm all world in pulmonary. I don't want to just limit myself to one disease. I could see that might happen. I went home and told my wife that they want me to do some other disease process called sarcoidosis. She said, what is sarcoid? And she go, the Lord wants you there. You got to listen to your wife, and if you believe in the Lord, you got to listen to the Lord. So on two accounts, I had to step over into it. So the door was open, and people started showing up with sarcoid, all varieties of sarcoid. I would be so happy when they just had mild disease and did not require treatment, because we all know what the best treatment for sarcoid is, don't you? Steroids. No. Pardon? Steroids. No. Having to do nothing. But a well, there, now, you're okay, you don't need anything. That's the best treatment. Now, beyond that, there are other medicines we use for treating sarcoid, steroids, methotrexate, this and that. Now, there have been a whole bunch of treatments and things like that. But the best, I used to love to do that. People come in with sarcoid. So I don't think you need much of anything right now. Let's just watch this and see how it goes. I'm pleased to do that, and I hope that they were pleased to have that happen. But one thing we did learn over the years is not to use a lot of steroids, because you have sarcoidosis, and we do not want to create steroidosis. There's too many steroids, blowing people up, and et cetera, et cetera. I was at a conference in New Orleans a few years before I retired, and I was sitting up front, and there were a lot of people who was, talking to me before the conference. They were on as high as 200 milligrams of prednisone a day. And a lot of them in a seating area was at 120, 150 milligrams of prednisone a day. They go, what? Oh yeah, I was taking that many a day. I'm like, goodness gracious. So as I started into the program, it was just Tulane University is where it was. You found out that they really did not know a lot about sarcoid there, because it was just steroids, high dose steroids. And so I think the education group that was there, Dr. Robert Hoffman and other folks, people from Cleveland Clinic, were educating the caregivers there on how to use other medications, low-dose steroids, and the best treatment is having to do no treatment. But so we try to educate our patients on that as well. So over the years, I got to the point where I had my clinic was 100% sarcoid. If you didn't have sarcoid, you couldn't even get in to see me. Then I got kind of burned out over the years, got older, and time to hang up the shingle. So I reluctantly hung up my shingle. My wife was happy. I wasn't too happy about it. I still wish I was there, punching in the clock. We don't have a clock to punch, but you understand what I mean. Still taking care of the patient with sarcoid. But listening to the people around at this table here, you're going to be in good hands, you're gonna be in good hands. I hope that there are people around the country, and I used to meet some of those people at different sarcoid meetings, because unless you're interested, you're not gonna go to a specific sarcoid meeting, the caregivers. But I can tell from what they were saying that I'm leaving the treatment of sarcoid into capable hands, and they're sitting at this table as we speak. Thank you very much.
Thank you so much, and Christopher, if you can collect the cards while I'm talking. And everyone asks, well, how do you come up with these events and how do you get these people? And I'm gonna tell you, I was diagnosed with sarcoidosis in 1994. December of this year will be 25 years of being on the sarcoidosis roller coaster ride, is what I call it. But in 2008, when I had my major flare-up, I hadn't gone to Pulmonary in a long time, but I went down there, they got me in to see Dr. Bowles, and Dr. Bowles, and I want to tell you how sweet you are. You may be knowledgeable, but let me tell you about you. Walked in, and then he says, do you pray? That was the first thing he said to me, and I'm like, yeah, do you? You know, and it went on from there. And, you know, he had his rules. You gotta be on time, take your medication. If you're gonna stop it, call me. So, you know, when he left, reluctantly, I was like, okay. But I'm a big girl, he taught us well. He taught me, you know, what to do, how to do it, even though I do doctor on myself. And then so Dr. Nair, he says, well, how did you find me? I was like, okay, well, I called Beaumont, went on their website, and he had this video. So you gotta go on Beaumont's website and see his video. So that's how I got, that's how I got with Dr. Nair. So when we had our Caring Hands group, everybody raise your hand, everybody in a purple shirt. We were sitting down talking about what we were gonna do for 2019, about better health, about educating, about preventative measures, not to go to the ER. The ER is not our friend. You know, how do we stay out of the ER? So when I asked, talked to Dr. Nair, he immediately said yes. Dr. Medici called our office. Whoever answered your phone is the loveliest person. And so, you know, you get a feeling of people that they're compassionate and they care about your care. So that's how all of these panelists are on the stage, because they care about us, they care about health, they care about their specialty. So I just want to say one more other thing about this blue folder. And I don't even remember what year Sharon was trying to get a proclamation for Sarcoidosis Awareness Month for April. I was trying to get the same thing. We were talking, come to find out, we're cousins. She has a group up in Ann Arbor, Michigan, Unstoppable Warriors. So let me tell you about her. You think I go, Sharon goes. And not only is she a sarcoidosis warrior, she is also a breast cancer survivor, 1 year. 1 year and counting. So she's been up there talking to all of our representatives. She knows everybody, Gary Peters, Senator Stabenow, she's been to everybody's office. So this is our proclamation for this year. Recognize Sarcoidosis Awareness Month for the month of April. So she's still working, because we have 2 bills out there, Senate Bill number 238 and House Bill 4422, that will make Sarcoidosis Awareness Month recognized in the state of Michigan from now on, after our lifetime is over. So you all write that down, Senate Bill 238 and House Bill 4422. So just know that there's a lot of people here in Michigan fighting. And Michigan, I want to say, you know, I love Michigan. We're the top of everything. So when it comes to support groups, we work together. And when it comes to just connecting with everyone, I think we're the best out of all of the states. So, Christopher, do you have the questions? just give them to Dr. Nair, and he's gonna take it over from here. Okay, that was it. Okay.
I'm not used to sitting, so I'm gonna just walk around and be with you guys, okay?
Oh, and Dr. Nair, just
Sure.
let them know that doctor has to leave at 3. So
Sure,
see her get up and
sure.
go, that's why.
We do have some time. Maybe I'll find out a cardiac question first. So the question that came up, number one, is it's pertaining to someone had asked about treatment for particularly sarcoidosis in the liver, and if there is no lung involvement, should we see the lung doctor? Can you raise your hands who asked that question? Is there any other thing that you would like to clarify?
Recently, well, a year ago, I was diagnosed with sarcoid. Well, I've been diagnosed with sarcoid in the liver for a while. Now I'm at stage 3 liver failure, which is also, I have cirrhosis. I see a liver specialist at Ford. They don't know what to do about the sarcoid. I went to U of M. They know how to treat the cirrhosis, but no one can seem to treat the sarcoidosis.
So I'll take the first shot, and maybe I'll pass on the mic to everyone else too. One of the major things with sarcoid, as Dr. Calvo was mentioning earlier, is no one patient is alike. Or in other words, no snowflakes are ever alike. And unfortunately, sarcoid can affect the GI tract, like stomach, liver, and the rest of, and even colitis too. Although sarcoid is very prevalent, it's not that as common with the liver per se. About like 3 to 6% of overall patients have sarcoidosis affect the liver, and it's not common to diagnose it without having the proper biopsy or even like MRI features suggesting that you have like nodular sarcoid. And even though most patients who have like hepatitis and other diseases can affect the liver, usually it's not the same enzymes that affect the liver. In patients who have sarcoidosis, it's a different type of enzyme that goes up called alkaline phosphatase and GGTP. And not everyone who has cirrhosis ends up, or not everyone who has liver affected by sarcoid is affected or progresses to cirrhosis to that fact. So usually when it comes to treatment, we often start treatment once you have to have a confirmed biopsy. So the number one question is this image characteristics, so confirming that this is sarcoid or not. And is there any other parts of the body like skin or like lymph node that we can biopsy to confirm the diagnosis of sarcoid? So the first part would be confirmation. And if it is only in the liver, we might end up doing biopsies to prove that there is granuloma in the liver. The second step is once it's extra outside the lung, extra pulmonary sarcoidosis, we often end up starting some sort of treatment. And initially it is with some sort of steroids at a certain dose. But the problem with that is it causes itself a lot of different side effects. And the most common second line agent that we use is a medication called methotrexate. And even in those patients who don't take don't have liver problems and start taking methotrexate, they end up, we require to at least like monitor their liver function very closely. So it becomes a double-edged sword, like how best to treat them. And that's why most sarcoid experts find it hard to treat them, because not every single drug is every single drug that potentially can treat sarcoid can have some sort of liver damage too. So we end up starting treatment. I would recommend you to actually see someone in the sarcoidosis field who actually feel comfortable starting second line, third line, and fourth line agents to treat. Without treatment, almost certainly, if it has progressed to cirrhosis, there is nothing worldly that we can do in preventing the granulomatous inflammation. But in the early stage, of course, we have to start treatment to prevent progression. Fortunately, only very few patients would require liver transplant. And that's like 0.03%. So it's not that common that people with sarcoid would end up requiring hepatic or liver transplant for that purpose. I would try to see what Dr. Campbell has to say.
Thank you. I'm sorry to hear about the complications of your sarcoidosis. Your case underscores the importance in sarcoidosis of a multidisciplinary approach to the management of sarcoidosis. In your situation, an atypical presentation of sarcoidosis leading to the damage of an organ that is not usually affected by sarcoidosis makes it very challenging. In that situation, the most important portion for you is to be in a center where not only you have the expertise of a hepatologist, but also you have the expertise available of somebody that is experienced in sarcoidosis, and that the approach is not like the hepatologist is in one side and the sarcoid specialist is in the other. The most important thing is having a multidisciplinary group that can discuss your case and give you the best recommendation from the hepatology perspective and the sarcoidosis perspective in order to come up with the best plan in terms of treatment. In your situation, immunosuppression. I think that we try to do this in all the patients with sarcoidosis, but when the presentation is atypical and affects an organ that is usually not affected by sarcoidosis, it becomes more important even in that situation. So I think that's the bottom line and the main message for you, recommendation for a multidisciplinary approach and asking for your doctors to talk to each other.
I have to actually do say, like, even though as part of this panel that we are describing all this and answering your questions, I would ask you to go back and take those answers and questions back to your own doctors and have a discussion with them rather than just having the panel dictate care. But the second question actually is a corollary to the first question. So the question reads, it is difficult for me to find treatment. I don't have a pulmonary issue. I have sarcoidosis in my bones, sinuses, skin, and I'm having equilibrium problems from falling several times. So this is not an uncommon thing to hear too. Can you raise your hand? Okay. Dr. Bowles, if you don't mind answering.
Yes, I had a number of patients who had no lung sarcoid, who had sarcoid. Can you hear it? Can you hear now? Had sarcoid of other organs. So what I would do is I would start treatment if they were symptomatic and with small dose of steroids. I never used large doses of steroids. Now back when I was growing up, it was blasting with 40 and higher doses of prednisone. But we learned that that wasn't necessarily a good thing to do unless they had maybe neurosarcoid. But if they had other multisystemic disease, and I would like to start a low dose prednisone, low dose methotrexate, give that a trial a few weeks and see how that worked out, monitor them closely. And a lot of times it did work out. Sometimes it didn't, then you have to step up to some other agent. And some of the other agents that would come into line would be some of the other secondary, tertiary forms of therapy. And someone would even eventually end up on some of the way out medications that we have used in the past, but very few had to go that far. Most time, low dose of prednisone accompanying some other medication was effective enough to control the symptoms and the progression of disease states. And this is something that has been recommended by the Sarcoidosis Disease Association that I belong to. Yes.
What kind of
I'm not sure what kind of doctor to see now because it's anything but pulmonary. I've had problems with my legs. I was up in the University of Michigan and I was seeing a pulmonologist, but I didn't have that kind of problem. So they sent me to someone about my legs would swell. And then I was going to someone about my sinuses, and I was going to an eye doctor, and I was on so much medication, I was toxic, trying to find one doctor that could handle it because it was not in my lungs. And now I'm having this equilibrium problem where I'm falling, I'm using a cane now. I went from a walker to a cane, and I don't know what kind of doctor to find.
So, go ahead.
I was going to say, I would encourage these two sarcoidosis doctors that are here today to pick up, if they haven't picked up the mantle, to pick up the mantle to be, if you're going to take care of sarcoid, take care of the sarcoid, not just necessarily in the lungs. So you're not going to find too many people and other specialists that's going to know as much about sarcoid as the people here. They have interest in it, and I mean, that's what we decided to do. Dr. Robert Burke, who's down at Troy Beaumont, but he's doing ICU and some other stuff, but we decided that we would like to be the, I'm not telling you guys to do this, but I'm suggesting that you become the quarterback of taking care of sarcoid patients, period. No matter where it is, if it's in the big toe, you got it. If it's at the tip of the ear, you got it. And let the other doctors run around that. But you take care of people with sarcoid. That would be my strong encouragement to these young doctors who are here today.
If I could add to that. So that was the approach we used to have when we worked together at Ford, where we would just take care of sarcoidosis with the support of other specialists. And that's the way personally I try to practice in terms of sarcoidosis because, I'm sorry. Just to recap, that's the way we used to practice when we worked together, and that's the way I want to practice everywhere that I go in terms of sarcoidosis, understanding that there are very few doctors that are comfortable with the treatment of sarcoidosis. If you go to different institutions, the sarcoid doctor may be in a different specialty. So for instance, I know in UIC in Chicago, the sarcoidosis person that will take care of a multi-organ sarcoidosis patient will be a rheumatologist. But if you go to Cleveland Clinic or University of Cincinnati or our own center, probably the best geared specialist will be a pulmonologist with certain interest in sarcoidosis. So unfortunately, there is not a national or international guideline about who should be taking care of sarcoidosis. Many times we refer to sarcoidosis as an orphan disease because most specialists look at sarcoidosis and they basically say, oh, it's not affected by the organ that I'm specialized on, so I'm not going to make a judgment or even treat it. In our situation, we understand that situation for that with the patient. We will try to treat it, understanding that I'm not an ENT doctor, so I would need the support of an ENT doctor if you have sinus sarcoidosis. Understanding that if you develop uveitis, inflammation in your eye, I need the support of an eye doctor to evaluate how the inflammation is. I will take the lead in your immunosuppression and screening and looking for sarcoidosis compromising our organs. And I'll be the quarterback. But unfortunately, nationally, this is not something that every place does. And in every single hospital, every single health system, you may not be able to find in a pulmonologist the person that will take care of this. You will need to work around in the institution or locally where you are to find the person that is most interested in sarcoid that may help you the most. But personally, I think Girish and I, and as Dr. Ball said when he practiced, we try to be that quarterback. You know, like, okay, let's see how active is your disease, what is the best treatment for you, do you have any other disease? oh, it seems that it's mostly cardiac, okay, well, we'll send to cardiology to evaluate you. But we try to take that role. You will not find that in many places, and it will be difficult for other patients to find that person in a particular hospital or health system. But we take that approach.
So, bottom line, what we are trying to imply is like have your care in a center where there is sarcoid expertise and who can care for you in a multidisciplinary manner. Move on to the next question. I experienced cardiac arrest but was told that sarcoid was not found to be in my heart. Could cardiac arrest be one of the symptoms? I would like Dr. Meradici to answer this. And if you want to raise your hand who asked that question, wonderful.
Okay, thanks for asking that question. It is true that many times, unfortunately, the first sign of cardiac sarcoidosis is sudden cardiac death. And so I don't know the specifics of your presentation, but were you found to have actual blockages in your heart arteries, or was it thought to be an electrical event?
I was first diagnosed in 2016. I went in with pancreatitis, and I woke up 3 weeks later, and they said I had lung disease, pneumonia, complete kidney failure, and I had went into cardiac arrest, and that required CPR. But afterwards, now I've been going to a pulmonary doctor and a rheumatologist, and so far they're telling me it's not in my heart. I had a cardiac consultation, but I'm not on any kind of cardiac medication.
Yeah, it's important, first of all, to determine that you don't have any blockages in the heart arteries. And if your coronary arteries are completely clean, usually we proceed with some kind of imaging of the heart muscle, so cardiac MRI or PET scan. And even doing a monitor, for example, for 30 days, or getting a loop recorder, which is an implantable monitor that can be kept in for several years to determine if you have some underlying electrical problems, I think makes sense. You know, certainly someone who's had cardiac arrest as a young woman, I think you deserve a little bit more kind of serial investigation, because it is true, cardiac sarcoid perhaps initially when it was looked for wasn't detected, but it's not to say, you know, who's to say that it may become more evident down the line. So I would encourage you to continue to have cardiac follow-up. Having been a survivor of cardiac arrest, you definitely need imaging, you know, throughout the years, and potentially a treatment plan if it's discovered you have ventricular arrhythmia or heart rhythm problem. So I think also, you know, heart healthy lifestyle in general, I think makes sense. Do you know if your heart muscle is normal or is it weak? You just don't know, yeah.
I mean, as a question, Dr. Meradici, do we need to do EKGs or any other certain specific cardiac imaging that we need to do in all patients with sarcoid? Or who should have routine testing?
Yeah, so it's an important question, because as you know, the statistic that I threw out earlier, it's thought that almost 50% of sarcoidosis patients have some kind of cardiac involvement that does not initially present as symptomatic. So it is important for sarcoid patients to have cardiac follow-up, because one of the potential fatalities in sarcoidosis, even though most people live very, you know, just normal lifespans with it if they have mild disease, can be cardiac complications. So yeah, I do recommend that that cardiac surveillance is a priority. I think because it's a multi-system disorder, people, you know, doctors, patients, they get focused on the pulmonary findings, or the ones that are most obvious, but not on the cardiac complications because those may be silent, and then unfortunately in your case, and again, we don't know if it's sarcoid or not, but can present in a near fatal way. So it is a good idea.
Dr. Bowers,
Right, for the last 10 years of my practice, I only went to sarcoid conferences. And at most of all those conferences, the burning question is, well, how do we try to clinically suspect cardiac sarcoidosis? And they came up with two questions, two simple questions. All your patients have sarcoid. Have you had chest pain? Okay. And do you have palpitations? And we had a questionnaire. If you had chest pain and palpitation, you were gonna, that week, get a cardiac MRI, or at least a 48-hour cardiac monitor. And if we had a strong suspicion, we went directly to the cardiac MRI. If we had, maybe not, we'd go for the other thing first, 48-hour cardiac. But then we picked up a lot of cardiac sarcoidosis that way.
as I mentioned earlier, a lot of the sarcoidosis may not be that apparent. PET scan is also another modality where we can show like active inflammation if it is there, cardiac muscles. And it's not like Dr. Medici mentioned earlier, it's not always the coronaries or the blood vessel that supplies the heart is affected. It's usually the muscles that are affected more, or the channels that are affected more, and that can cause like arrhythmias and cardiac arrest too. So it's very important, as she stressed, that you have routine follow-up, especially as a cardiac arrest survivor, and have very close monitoring of the heart and have all the cardiac testing at a good place. I'll go on to the next question.
The lady in the green had her roots still, yeah.
Oh, there you are.
This is out of order, but I was diagnosed 22 years ago. I was asymptomatic. My mom had the disease and passed away a year before I was diagnosed. I'm on prednisone. I've tried methotrexate, Cellcept. Prednisone seems to be the drug for me, pulmonary. But you talked about chest pain. I've attributed my chest pain to I've been on prednisone for 9 years. And I just wonder if others in the audience have that too. I just had an experience 2 nights ago, and it's just a grabbing sensation in my chest. And it lingers, and it sometimes feels like it's 30 minutes, 60 minutes, may only be 10, 15. And then it subsides, and then sometimes it comes back. And he's experienced it with me. We'll be traveling in the car from Detroit back to Lansing. And I have to, he'll pull over so I can kind of stretch a little bit and relax. But I just don't know if it's anything to do with a cardiac muscle issue or if it's just the prednisone effect.
Well, I will encourage you to discuss with your providers. If there are many things in your situation that may be leading to the chest pain. After a certain age, regardless of the gender, chest pain may be an indication of a coronary artery blockage, regardless of whether you have sarcoidosis or not. So this needs to be followed up on. You need to bring this up to your provider. It could be an early sign, or it could be a sign of cardiac sarcoidosis, so that's also what your sarcoidosis specialist needs to be aware of, because when we see patients in clinic, sometimes the way we screen or we order tests, it depends on what we hear in terms of symptoms. And as Dr. Ball said, we will have a different threshold to order the most specific but most expensive test, depending on what we're hearing for patients. I will encourage you, it can be nothing, or a chest wall inflammation. It can be coronary artery disease that can happen to anybody, not only patients with sarcoidosis, or it can be related to sarcoidosis. So I don't think anybody in this panel is able to give you an answer right now, but we'll encourage you to follow up with that with your providers, because it needs to be looked at. Because you have sarcoidosis, more testing may be needed.
So 2 points. If you look at like big epidemiological studies in patients who have sarcoid, their chest pain is not that uncommon. There are a lot of patients who have had with sarcoidosis. Even they might have fatigue, low-grade fever, and chest pain is one such symptom too. It could be, as Dr. Calvo mentioned, other etiologies like acid reflux and esophageal spasm or inflammation in the muscles and the bones, but you never want to overlook something like a bad heart disease. And that's something, according to your age and risk stratification, you might want to talk to your doctor and have advanced testing. Okay. Let me go on to the next question. Dr. Kova mentioned that she lost all the fat in her body due to sarcoidosis. Can sarcoid cause muscle wasting? And let Dr. Kova tell her experience, and maybe Renee can follow up on what we do in the pulmonary rehab.
So with me, I didn't have that right away. When I was 19 years old, my face started to change. My mom started noticing, but you know, we went to different doctors and they couldn't really figure out what it was. Through all different tests, I did find out that I was allergic to certain foods. So I eliminated some of those things, and if I ate some of those foods, I would wake up with swollen eyes. But by the time I was in my 20s, the swelling in my face turned hard. So I had like hardness in my cheeks and also under my neck. So it was all here and all around the eyes. So over time, like I used to work in cosmetics when I was in college. So people thought that, you know, I had some other issues happening, like domestic violence issues, because that's the way I looked. So it was pretty bad. So after I had my son, my face, my eyes were swollen like bowling balls. And so at the time I was teaching and working at a college, and I had to wear sunglasses to work because my eyelids were backwards. So the hair on the lashes were in my eyes. So everybody was trying to figure out. My parents, they were kind of, I'm first generation American. My parents are from Liberia. So we didn't know what was going on and stuff, and tried everything. I was on prednisone for a while, and you know, I had some good results with it, but then after I turned around 29, the swelling in my face started to go down and the hardness started to go away. So I was like, okay, finally it's going away. But then everything else, I don't know, they did do a biopsy behind my ear, and they did one in my neck and took out lymph nodes and tested them, but they just said that I just had some abnormalities, and they didn't really know if it was sarcoidosis or not. I wasn't really diagnosed with sarcoidosis until later when everything was gone. So what I mean by everything was gone, you could see the muscles in my face when I talked, or you could see everything. So all of this, like from the orbital area, like the cheekbones, all of this has been refilled. So I had nothing in my face. Also, some parts of my body, I'm like, could have took my stomach, but just decided to take my arm, so people think that, you know, I work out heavy, but it's just the fat is gone. So you see mostly muscle and, you know, skin and bones. So I really just had the physical things happening with me, but I really wasn't feeling like really sick until I was, my son was around 2 years old, and I thought that I was expecting again, but my immune system was kind of not doing so good. So I went into the hospital. I was there for 10 days, and then they took tests from the other biopsies that I had at Cedars-Sinai and UCLA, and they compared them. And then at that time I was diagnosed with a kidney disease, FSGS, and then my sister, when she started working at Woodhull University Hospital in New York, that's when she was talking to another specialist, and they figured out that I had lipodystrophy. And so I don't know if the sarcoidosis, you know, helped with the other situations that I have going on. But from that, I just cut out a lot of food, and so I'm not on any medication currently right now, but I wasn't well, but I do have, if you see me limping, I do have arthritis in the hip, I'm not 40 years old yet next year, but I'm just like, okay, well, walk around my cane. And I kind of like to joke about it because I can feel bad and I can cry. Sometimes I do. But I just try to say, hey, I'm still on this planet and, you know, this stuff happened, but, you know, and so grateful that the show has highlighted it because so many people from around the world, you know, contact me. I don't know really why this happened, and you know, I rely on my sister a lot, talk to her a lot, and doctors that I see, and I'm learning a lot from the panel.
Dr. Bowles, in your wide experience, do you see sarcoid affecting the muscles and fat tissue causing lipodystrophy?
I haven't seen that, at least I haven't recognized it. If I did see it, I didn't recognize it. I've seen a lot of sarcoid in the bone, and for those who have it in the bone, I haven't found any medication over the years that has been quite effective, except for one, which is very, very hard to get, and that was using Acthar gel for that. But I think for the last 2 or 3 years of my practice, I had 2 patients with isolated bony sarcoid biopsy proven. And I went through the usual stuff, the steroids, the methotrexate, the this and that, and they just come in and look at me and like, "Doc, you're not doing squat. This medicine isn't helping." And I refused to go to those higher doses of steroids because I didn't want to produce steroidosis. So I learned about this Acthar gel, just some programs, and I go, well, you know, so we get them authorized. It was hard to get it authorized, but when it's got authorized, they did very, very well. I mean, that's patients too. So I mean, sure you like to have more, I mean, a study to do it, but with 2 patients, that's all you got. But it worked in those 2 patients quite well.
What is steroidosis?
Steroidosis is just people taking too many steroids. I'm sorry, you take too many steroids, you blow up like a balloon. That's what I call, that's Dr. Bowles' medical book called steroidosis.
And doctor, I had that, it happened to me on my last hospital stay. The doses that was given to me, I blew up and my legs were bleeding at that point, and I had to walk with a walker. There's a lot of different stuff happening. It's just kind of ridiculous.
That's extreme steroidosis.
I'll come back to bones and sarcoidosis and role of vitamin D.
If I may.
Yeah.
Sarcoidosis is not only, the side effects from steroids are not only regarding the weight, it's just diabetes, high blood pressure, all the mood changes, insomnia. So there are so many things that the steroids can give you that's why we always try to give you the least amount of steroids as we can possibly do.
So this question is regarding the hours of rehab. And there was a second question, can a person discontinue oxygen therapy through pulmonary rehab? I'll have Renee take the first question and explain the benefits of rehab in patients who have sarcoidosis, and maybe Heather can chime in on oxygen.
Okay, so regarding pulmonary rehab,
Who asked this question?
okay.
The reason I ask this question is because my pulmonologist believes that I may be a good candidate for it. However, I am still trying to work. Most people are not working, so they can go to pulmonary rehab. My hours are always the same as pulmonary rehab, and I'm never able to get into the pulmonary rehab. So I want to know what their hours were, if at all possible, and can a person, I'm on oxygen, and I wanted to know if a person can ever discontinue. Have you ever seen someone discontinue using oxygen therapy by going through pulmonary rehab? And I was told the reason why I'm on the oxygen is like they were saying, you don't want to have the sarcoid in the lungs and have heart problems, so they got me on the oxygen to prevent any problems with my heart.
So let me just say that in particular, Troy Beaumont Hospital, we do offer a later pulmonary rehab, and those days are on Tuesday and Thursday. And we can take somebody in as late as 4 o'clock. And if there's special circumstances, we really do try to, we are looking at other alternatives as far as offering some late classes. and some late sessions
Yeah.
for
4
situations.
is not late.
Yeah, well, but we're one of the that's one of the later times in the rehabs, but, can I ask what time do you get out of work? Like
5.
5, and where, are you anywhere in the
I'm in Midtown Detroit.
Midtown Detroit? So, currently, I mean, I have to be honest, we don't have, because by the time you came through traffic, it would be,
6.
yes, it would be a late class. However, we are looking at other options because you're not alone. And we do want you to have a functional life. We do want to be, I always go for the analogies, but you know, when you see a relay race and, you know, like they're passing off the baton, we want you to, we are in charge of running the race and we're passing the baton off then to you to carry on. And so we want to like light the fire, get you going,
Right.
and then have you lead that productive life that you and all of you deserve, you know. So I will take that back to the girls that I work with, and we will see what we can do. I, for example, teach smoking for the hospital, and that class is it's run on Mondays. For anyone, just throw this out there as well. For anyone that is has a pulmonary diagnosis and they are a smoker or they are exposed to secondhand smoke, I can't tell you how important it is for you to come in to, hopefully you want to come into Troy Beaumont's program, but Royal Oak Beaumont has a quit smoking program, St. Clair Shores has a quit smoking program, all through Beaumont, as well as these are the sites also for pulmonary rehab. Get involved in that quit smoking program. It's a very non-judgmental, it's like a cheerleading process to get you to the finish line of quitting smoking, because that is just so imperative. But one of the things I'm thinking, I'm already there Monday nights, so, and maybe I could extend my hours another way and bring you in on a Monday night. I mean, we have to start thinking outside the box for our patients, you know, and so I'll take your number at the end, and then I'll just see if there isn't just something we can do. We do like to have 2 therapists in case there's any complications with anyone having an issue at our rehab, so that you're protected and you're safe. But I do want to say that as far as once you're in pulmonary rehab, we are going to, you are under our wing, and you are our first priority to get you to a better spot. We fully embrace the process of getting you stronger and getting you doing things more efficiently, using your breathing techniques, using energy conservation, knowing when to call the doctor. Many times, patients come in and they're just starting a flare with their breathing, and we are those folks that make the connection with the doctor to say, now wait a minute, like it's not, we can't have you exercise today, but we're gonna call your doctor and see if we can't like be that bridge to let the doctor know your symptoms you're experiencing. We are such a valuable resource, so we need to be utilized. We need the community to know that we exist for you, and we are there to support you in many ways. So we make sure you're taking your medications correctly. There's many devices out there for different inhalers. We go over infection prevention and, you know, all of what comes with that as far as avoiding those hospital admissions, flu and pneumonia shots, all of that. And together we make a really great team. So I hope that all of you here today would consider speaking to your physician about coming into pulmonary rehab, because we are a vital step in the process. And the handout in the back of the room there is, we are working towards certification with the American Academy of Cardiovascular and Pulmonary Rehab Association. And actually sarcoidosis is one of those disease entities that is listed right on there for being a vital resource for, you know, for better life. So please do speak to your doctor, and I would encourage you all to take the physician part that the physician signs off, and bring it on into your doctor so that we can get you in and we can help you out. And then to answer just from my perspective about possibly weaning off oxygen, just like the panel said here, everybody is individual. I could have a room of people under the COPD umbrella. I could have a room of, everyone has their own story to tell and their own, what their personal best is for their day. But I will tell you, can we get you off of oxygen? It's always on our radar. If that's your goal, we are gonna monitor you and work for that as long as it's safe to do so. And so if we can get you on exercise equipment and your oxygen level is nice and high, and your heart rate is in an acceptable level, we're gonna start titrating you down. That's part of what you come in under that's part of the physician orders bringing you into our program. And so we'll titrate you down. Now, was it a fluke, a good day? Possibly, but if we can trend that and we can show that we can keep taking you back on your oxygen, and then now we've weaned you completely off and you're on that treadmill, we're gonna keep monitoring. And then we make the phone call to the doc, and it's a happy moment for us. I mean, us in rehab have shed tears with the patients that, yes, we've gotten you off. And is it realistic that you could be off 24 hours? Possibly. Could you need to maybe be on oxygen through the night? Possibly. But, is it safe to say that we've had you on fairly high workloads and we've gotten you off your oxygen? Yes. In some cases, it's yes. Is it for everybody? Many times not. But if that's your goal, we're working for that for you. We want that for you.
Thank you.
I'll just add on, usually, and I've been the director of the rehab program here as well as back in New York where I first started working, usually pulmonary rehab per se does not improve your lung function. That's not the idea for the rehab per se. But exercise in itself has a lot of different benefits. It does release a lot of endorphins in our body, like a lot of us are, whether it's due to medication or with other reasons with sarcoidosis, most of our patients do experience depression and anxiety and all that. And exercise do help with that. It helps with bone strength, it helps with muscle strength, it helps with stability. So there are a lot of benefits with exercise, so I strongly do encourage that. The need for oxygen therapy versus not, it also depends on how much of inflammation there is in your lung per se at that point in time. If at some point you had a lot of inflammation in your lungs and you require oxygen, it need not be continuous if the inflammation is gone. So we have patients with sarcoid who had the disease process and had inflammation, started on therapy, and it improves and you don't need oxygen further on. But there are other patients who have developed already more like scar process in the lung, or had developed increased pressure on the right side of the heart due to the scar process. It's not that easy to wean those patients off oxygen. So again, as we all, right. So as we mentioned earlier, it would be, it has to be tailored to that particular patient, and no patient is alike. Okay.
Can I jump in real quick?
Sure.
To piggyback on that, I have a list of all metro area pulmonary rehabs. So I'd love to meet you after.
Okay.
And then we can swap emails, and then I would love to try to help you along with respiratory to find you something that maybe would be more conducive.
I appreciate
Because I have
that.
a list of probably 40.
Wonderful. Thank you very much.
No problem.
All right. I'll go on to the next question, and probably Dr. Kofa and Dr. Medici can chime in a little bit. It's about homeopathic treatments, including salt therapy and ocean air, if there are any benefits. And who will ask this question? The second part, I will try and answer the second part. Good.
We spend the winter, the last 5 years in Hilton Head. We rent a condo there, and within a couple of days, my energy level soars. I don't feel the fatigue. I'm not napping every day that I'm home. I don't stay in my PJs all day some days when I just feel better. It's still, we're there 3 months, so it's not like a vacation for a week. We're there and I'm doing cleaning house there. I work from remote. I still work, and I just wanted to know.
Ironically,
I love this question.
we were just talking about, we were both in Florida, and we both felt good.
So, interestingly, there is a science, quite an old science, in fact, ancient science, called thalassotherapy. And that refers to the health effects of being by the seaside. So seawater has many minerals, iodine, magnesium, calcium, sodium, and many disease processes, including many autoimmune conditions, inflammatory conditions, are known to improve at the seashore. So my own kid is 4 years old and she has severe atopic dermatitis, eczema. And I was just telling Dr. Nair, we just got back, and we go every 3 months because this child in 24 hours, it's like her skin regenerates and she's happy. Otherwise, it's just like a maddening itch that's like 24 hours a day. So, so it is true that many conditions, especially respiratory conditions, improve, and the aerosols in the sea areas are known to open up airways and to reduce inflammation. So in Europe, actually, more so than in the United States, there are actually, there's a medical field where doctors will prescribe thermal spa therapies. There are various lakes with various properties and springs and ocean resorts and things like that. So it's not just your imagination, in other words, okay? And who's to say that, you know, vitamin D that you're getting more so there than here? I know there's controversy with vitamin D and sarcoidosis. Many of you have probably read this. I actually recently read an article about this. But probably the combination is helping some element of your inflammation. And I have many patients who have, for example, Raynaud's disease or other inflammatory conditions, and all say within 48 hours, I've seen even remissions of Crohn's disease, and 48 hours of flares, and then come back to Southeast Michigan and things are back to normal. Now, there is, you know, we all say that no one knows what causes sarcoidosis, right? That's kind of a frustrating thing to say about a chronic condition that causes so much debility. And it's almost unfair to say that, right? I mean, we have all this knowledge and all you know, it's 2019 and we don't know what's causing sarcoidosis, really. But there are, there's a lot of evidence that it may actually be an environment, not just one, but several environmental triggers. And so I encourage all of you to kind of look into that. And there's everything from potential heavy metal toxicity to pollutants to, you know, there are many. So place does play a role in how you feel in general, not just with sarcoid. What are your doctor?
Well, actually, Dr. Gofa, because you mentioned about the importance of diet, and since you're from California, we get that.
Well,
Maybe we should all go together.
we were just talking about when I had to fly through Chicago, there was nothing for me to eat, so I pretty much just, because I'm vegan, gluten-free, and soy-free, and so because I guess with sarcoidosis, it's your inflammation, you have a lot of inflammation, right? So I try to stay away from foods that that cause any type of inflammation. So I try to cut those out, and because of the kidney disease, with you know, the spillage of protein, I didn't want to have a lot of animal protein in my body, and actually I felt kind of bad when I would eat, you know, I still you know, miss pork chops and different things like that, but I've come up with a lot of different recipes of like burgers and a lot of tacos and different things like that, so that I'm not just eating salads, because I've never been a salad person. But I also like to not have a lot of stress, so if I have friends that are kind of problematic, I love them, but if they're too problematic, I just listen and go, okay, and then I just kind of back away and let them go through their Tasmanian devil experience by themselves, because I can't do that, because what it's gonna do for me is it's gonna kind of ruin everything for me for a couple of days. I'm gonna be a little bit more tired, I'm not gonna be able to function, and I do a lot of different things, and so I need my energy. So for me, you know, when people get to know me, I tell them that, you know, I'm kind of reserved, but I like to, you know, just kind of relax and try to eat foods that don't have a lot of salt and different things like that. And I know it's not really hard for people, especially if you love what you love, but over time I had to kind of adjust and, you know, taking walks and just keeping my stress as low as possible. And there's a lot of things that you can't control in regards to stress, but I just say, okay, those things are what they are, and anything that I can control, or if I have to come back to it another day. But, you know, whatever I can do to alleviate stress in my environment with people and friends, and just try to eat, you know, as good as I can.
And in any kind of stress, actually, whether it's stress to the body, like you're getting surgery, or an infection, or even stress to the mind, it has been shown, can flare up a lot of these chronic diseases, including sarcoidosis. So definitely, less stress it is in your life, the better it is to tackle these kind of problems. Next question, I will move on, and maybe Heather can give an overview. Is there a website with information directory of the hospital's clinic dealing with specifically with sarcoidosis? Maybe you can explain how the multidisciplinary team functions, and maybe later on, Allison, I don't know if the website contains all the information regarding doctors.
So in regards to website, I would direct you to Allison, and then I brought some materials in the back about, it says, I think it's about being a champion of sarcoidosis, and the last page in there has about 8 different websites you can go to help you get connected and find more education, and almost all of that information is free. So Dr. Nair facilitates a multidisciplinary interstitial lung disease meeting once a month. I help get that off the ground, and what that is patients that we see or other pulmonologists see that are interesting and very difficult patients that we are looking to find out what is the best treatment option or where should we go to next. And so we meet sometimes here in this auditorium, and we will review chest CTs up above on the TV, and there's a group of doctors. Sometimes there's pulmonologists, several different pulmonologists, radiologists, we have a pathologist, rheumatology is in here, and they just kind of hash it out what the patient looks like. Here's what the CAT scan shows. Some of those patients have had biopsies. We look at the pathology slide, literally the slide. Pathologist chimes in and will tell us what that picture looks like, and then we kind of come together as a group on what is the next best course of action. So whether that be treatment, or maybe we decide that, yes, we need to move forward with doing a surgical lung biopsy. So that kind of goes back to the lady in the pink talking about finding a physician in a care network that presents your case, and where you can meet together with other physicians and they talk to each other.
How do you get your case in that group? So the question to Heather and Dr. Nair is, how do you get your case heard in that group?
So my email and my phone number is given out to all the physicians, pulmonologists, and if they have a case, they will either reach out to myself, they could reach out to Dr. Calvo, or they reach out to Dr. Nair, and then we present that case. But it has to be driven by a physician.
Okay.
Actually, it can be driven by anyone, except for the patient, but if it comes from the patient, then we require like someone actually is seen, like if it's a patient who wants to have that discussion, has to see one of the physicians who can actually present the case. We do, sometimes patients end up sitting in those panels, but it's mostly medical terminologies. that gets exchanged, so not everyone likes it. But it is a very good tool that we have out here with the multidisciplinary approach, and it helps solve some of the complicated cases. Not every case gets discussed, but it does help quite a bit. Let me move on to the next question.
No?
Go ahead.
Sorry. In terms of clinics, there is a list of clinics that are recognized by the World Association of Sarcoidosis and Granulomas diseases. It's in the FSR, Foundation for Sarcoidosis Research website, and actually we're in the working process to get a recognition from WASOC right now. So that's one good resource. There were only around 30 clinics recognized by WASOC as of last year or something like that in the world. The second thing that I will encourage you, and I'm happy this question reminded me, is FSR also has a registry of patients. So one of the main barriers for the advancement of the care of sarcoidosis has been that there is no research for many reasons in our sarcoidosis patients. One of the ways to overcome that obstacle is getting patients into a registry so we can monitor what treatments are they on, how is their disease behaving. They do have FSR, if I'm not wrong, at stopsarcoidosis.org. You as a patient can go there and be part of the registry. By being part of the registry, putting your data there, researchers can look into the data of all the sarcoidosis patients there, and we can see which patients are doing better, what phenotypes, what different types of diseases are we seeing. So I will encourage you all to go there to the registry and put yourself there to help us in the future take better care of you.
And I can say nothing less of doing research, and I'll let you talk about it too, but research is very key, especially in a multi-system disease like sarcoidosis, to come up with a cure.
I would like to add on to what he was saying regarding the registry. I'm a patient ambassador for FSR, and I have been for 3, maybe 4 years. Anyway, the patient registry, your names are not used at all. So a lot of people fear, oh, if I put my name in it, now I'm gonna get all this type of literature and all that. Your name is not used. You are assigned a number, actually. So your privacy is kept. It's strictly for research purposes, so that the more data that can be collected, the better we can find a cure, the better we can find better medications to work for us. So it's very important, just like the doctor said, very important to register.
Thank you. Let me move on to the next question. Are you aware of sarcoidosis in the bones with multiple myeloma? And overall, what's the prognosis? I don't know who asked that question. Very good.
So if I understand the question, you're asking if both conditions can coexist, multiple myeloma and bone sarcoidosis?
Right, that's my thing.
Well, as a general rule, I never say never in the field that I am. I have not seen that often. No, I have not seen it together. But that doesn't mean that they both cannot happen together. I don't know if Dr. Nair or Dr. Bose have a different opinion that I have not seen it before personally.
So, not in particularly regarding myeloma per se. As such, like people who have sarcoid, they are not prohibited to have other diseases like viral infection or other cancers and as such. But there hasn't been a lot of big studies that looked at like increased risk or odds of developing myeloma in patients who have sarcoid. And maybe that's something that we can look up in the registry and when it comes up. There has been reported case though of conditions, especially in younger patients, who have sarcoid, where the inflammation goes into the super overdrive, and they can develop a type of lymphoma. And there is a syndrome where there's sarcoid lymphoma syndrome in some patients. So not particularly regarding to what you have, but there are cases of certain types of cancer, including lymphoma, being seen more prevalent in patients who have sarcoid, and the treatment is slightly more different than the regular sarcoid treatment. Okay.
And if I could add, sorry, many medications that we use for the treatment of sarcoidosis predispose patients to the development of cancer in the bloodstream or the lymph nodes. So that's another thing that we need to always be cognizant. When we have had a patient in long-term therapy with azathioprine, Imuran, or methotrexate, that by itself increases your chances of developing lymphoma or leukemia down the road.
And that is true with any type of immunosuppressive medication. And the theme of today is actually to prevent hospitalization and to reiterate the fact, like, to prevent hospitalization, it's key that you have a working relation with your doctor, and if you're on any of those immunosuppressive medications, to have your blood work checked regularly to make sure, like, the kidney functions, the liver, the regular blood work, everything is working in tandem and not causing any major problems. Second and foremost, we talked about exercise, but the other preventative thing is like having your vaccination up to date if you're at the right age. Even like shingles, if you're at the age for developing shingles, you should get the vaccination, but not with the active virus if you are immunosuppressed. You have to have all your screening. If you had been a smoker for a long period of time and you still qualify for lung cancer screening, you should have lung cancer screening. You should have colonoscopies, endoscopies, mammogram, stuff like that on a regular routine basis. And as what Renee was mentioning earlier, exercise is key, and it's kind of like works like a vicious cycle. If you don't do exercise, your body and your muscle tend to become more flaccid, and then it becomes deconditioned. So it's important that you keep up with that regimen to prevent hospitalization. Actually, it's a corollary to the question that was asked earlier: why and how does sarcoid relate or trigger rheumatoid arthritis? And why Detroit? You can read the biggest rate of sarcoid, and is it hereditary? Dr. Balls, if you want to talk about it, with your experience.
Well, let me just be very simple. When I answer that, we don't know the answer to that question.
About being hereditary, you mean? Hereditary?
There are some cases that seem to be hereditary, but it's not quite clear. Certain areas seem to have a predominance of sarcoid-like diseases or sarcoid disease itself. That's still not that clear, but people are still working on that, but there are no answers just yet. There are no answers yet. But all we can do is see patients who have symptoms and it's discovered on an x-ray or skin lesion, or come in with arthritis, come in with all kinds of symptoms. And then later on you find out due to blood testing, et cetera, that is likely sarcoid. But it's not always just come in with some symptoms and boom, you got an x-ray, you got sarcoid. That's not always the case.
In the area where I grew up on Helen Avenue, about 2 blocks off of Jefferson, and we've done the research among the people that live in the area just by going on Facebook talking about sarcoid. I had found 15 people within a 7-block radius with different kinds of sarcoid. And I saw an article in the Detroit News about them having to dig 30 feet down to take out contaminated soil at the old Uniroyal plant that was on Jefferson. And I contacted the news, and I was contacting everybody that was associated with that story to tell them that so many of us that lived near that Uniroyal plant have sarcoidosis. Not all the same kinds, but there's a cluster in that area of people being sick. And of the ones that were sick, only 3 of us are living. But they say, you know, is it environmental? We don't know, but I think it's something that should be looked into, that so many people in a particular area have the same disease.
So right, the thought process right now is you're born predisposed to get a disease and then you're exposed to something that triggers the disease. We have not found what is that something. Just to follow up on that, in New York City, after 9/11, the prevalence and the incidence of sarcoidosis in the fire department and first responders went up high, and they have a high number of patients with sarcoidosis on treatment for an unknown exposure after that day. So it's there, we have, and if you see also sarcoidosis tends to happen in clusters in different places. So as I said before, in Norfolk, Virginia, we had a huge population of patients with sarcoidosis. And then you come to the Detroit area, it's one of the other places that every place you go in a conference with sarcoidosis, everybody knows that you are seeing a lot of patients with sarcoidosis. We don't know why. We don't know what that particular thing in the environment that has triggered that inflammation. But certainly that's a clue that we have to follow. The problem is, how do we get there, getting the funding for that research, and how to prove it. That has been one of the main obstacles.
It's the #1 leading disease for the first responders after 9/11. Sarcoidosis is. #1 disease.
I have to admit, I used to see patients for World Trade Center, and I agree, like, we had a lot of patients, and those patients were not the traditionally spoken cases where you tend to see more in females and African American between the age group of 20 to 40. These patients were slightly older or younger, but more Caucasian population too. So it's not that uncommon. And environmental trigger, like what Dr. Calvo was mentioning earlier, is key. The thought process is you have some sort of genetic predisposition and you have some environmental exposure, like the AXIS study and the other studies that have looked at overall, like epidemiological studies. They've shown like people who are exposed to farm and farmland and had pesticide exposure tend to develop more sarcoid-like reaction. Why? And as you constantly keep hearing, we don't know why, and hopefully we can find that in the near future. And to the earlier question, could you have rheumatoid arthritis or other connective tissue diseases related with sarcoid? The answer to that is yes. People who have sarcoidosis can have other rheumatological diseases, including Sjogren's and other autoimmune conditions. Do you want to chime in a little bit?
Yeah, it's not unforeseen, and sometimes it's very confusing. For instance, the lung nodules that are typical from rheumatoid arthritis, if you biopsy those nodules, they give you granuloma. And then you start thinking where this is sarcoid or the granuloma is related to rheumatoid arthritis. So there may be some overlap in the immune response that the body is doing, but it's not uncommon to see both conditions, being in lupus or Sjogren's or scleroderma, and sarcoidosis happening. Luckily, I think sometimes the treatment overlaps. So it helps you sometimes decide which agent may help both conditions. And yeah, I think not uncommon, treatment may overlap. And I cannot comment because I don't know the answer to that, whether the prognosis is better or worse, both are present. I don't know if you have, or
I don't think we have the data to support that, but we do tend to see people who have sarcoidosis. Some patients do tend to have like other autoimmune diseases like Sjogren's too, which is also a great mimicker, like how we always talk about sarcoid, it can affect any part of the body. this question is also pertaining to the same thing. Can you have asthma and sarcoid? Which is a very common thing that we deal with. Maybe Dr. Bowles can chime in a little bit, and then I'll go on to Patrick.
Yes, that is correct. I have had a lot of patients who had asthma who had characteristic features of sarcoidosis noted by x-rays and other biopsy findings that have that. Some, they ran the spectrum. Some had mild asthma, mild sarcoid, some had bad asthma, mild sarcoid, and just the whole spectrum of each disease could have been present. Didn't have a lot of patients like that, but we had enough to know that they could occur together. Never could figure out any reason and rationale for all of that, but it just one of those things that you notice in the practice of taking care of the patients.
So traditionally, and let me put into words, and then maybe you can explain that too. Usually when you do a breathing test, and not everyone with asthma would have an obstructive lung disease, like the airways tend to like collapse and be narrow. And usually in patients who have asthma, that tends, for some or the other reason, there are like triggers that causes bronchospasm, where the airways in the lung becomes much more constricted, and with the bronchodilator that expands. Usually in patients with sarcoid, you can have that, especially if you have endobronchial involvement in terms like people who have sarcoid in the lung and the parenchyma can also have sarcoid-like nodules within the bronchus and the bronchi. And we tend to see that when we do like bronchoscopies, where we tend to see these kind of areas which are involved and can cause very similar to asthma-like presentation. So you can have an asthma. You can have asthma coexist with sarcoid, but you can have also sarcoid that affects the airways and are falsely mislabeled as having asthma, but all along they had sarcoid within the airways.
Yeah, basically in that particular situation, it's a matter of being patient with us, trying to figure out what is the main process. Particularly if I see a case of mild sarcoidosis with not a lot of nodules in the lungs and having a lot of symptoms, wheezing, coughing, sputum, phlegm production, I try to give it a shot to the asthma treatment. And many times we have been able to come down on the dose of the prednisone to even take it off by treating the asthma. Unfortunately, it is not figured out in the first visit or within the first month. So that is one of the features about sarcoid care. It changes, and your doctor needs to see you and get familiar. And sometimes you need to try something and see if it works. And if it doesn't work, then move forward to the next step. Sometimes you are so sick, we have to treat both of them. So it's a challenging situation, but luckily many times, to me, the importance has been we have been able to take off the steroids taken by mouth and take care of most of the symptoms with just inhalers, which I think is great based on the side effects of the prednisone.
Next question. I have had several inflammation issues from plantar fasciitis to skin rosacea and eczema. Some doctors have said it is related to sarcoidosis, others says it is not related to. Saying the same question. We don't want to answer that.
I have no answer for it.
Those are not, I would say, not typically associated with sarcoidosis based on the research and cohorts of patients that have been diagnosed with sarcoidosis. But those are also common conditions in patients with or without sarcoidosis. Whether the dysregulation of your inflammatory system has something to do with the rosacea, for instance, I don't think that has been proven. We tend to see patients with both rosacea and plantar fasciitis. I don't think anybody is able, based on the available literature, to say this is related or associated with the occurrence of sarcoidosis. I don't know what you think.
No, so definitely there has been a lot of sarcoid related manifestations in the skin. You can have inflammation around the nose and cheeks and those areas. We call it rosacea and lupus pernio. That has a slightly worse prognosis as opposed to someone who has like inflammatory nodules in the shin. That tends to have a slightly better prognosis. But there could be like other like papular and macular like scar, different types of like lesions in the skin that could be related when we do a biopsy, that could be related to sarcoid. So sarcoid is known to cause a lot of different types of skin manifestations. So along with, it can also cause inflammation in the bones and joints, and pain in the joints is a very common manifestation with sarcoid too. So to reiterate what Dr. Calvo was mentioning and what Dr. Balls was mentioning earlier, we tend to have to see these patients very closely and find out if at all truly this is a relation with sarcoid, or this could be like a common condition that coexists with sarcoidosis. And that decision has to be made based on the information that we get from the patient. Go on.
You just mentioned something, and I was just, you just mentioned about the facial aspect of it. And it's been coming on and off, like in the area of my nose. And so I did notice that there's a lump and a bump. It comes and it goes, and it comes and it goes. Is that what you mean by the skin pressure?
No, so it can be, it need not be related to sarcoid, as I mentioned, but sarcoid can cause those kind of small papules that come up and go. And usually those causes, if you're not on treatment, more like ulcerative kind of disfigurement. So if it comes and it goes, probably not, but if it's something that's there and persistent, getting worse, potentially could be related to sarcoid. And we tend to see patients who are seen by dermatologists. We had a patient with like swollen lips from nowhere. And the dermatologist eventually biopsied that and figured out there was granuloma sitting in those lips. So it's protein manifestations. So you just can't pinpoint to just one thing. It could be any different things. And most often, and it's important, and we not really discuss in detail about that, sarcoid causes inflammation, right? And the type of inflammation it causes is called granulomatous inflammation. It forms small clumps like this. There are other things that can cause that too.
Okay.
There are certain types of infections that can cause the same kind of granuloma. Certain exposures, like to certain bird and avian antigens, can cause granuloma. May not be the same exact one if you look at like histologically, but it can happen. There could be like certain autoimmune conditions like Crohn's disease and other conditions that affects the bowels that potentially can cause granulomas too. So it has to be carefully looked at. Not every single granuloma is alike. And we tend to, when we do biopsies, whether it's in the skin node, lymph node, or in the lungs, we send routinely for cultures and make sure that you don't have like certain types of fungal infections, certain type of TB or those kind of related infections too. So it's an exclusion of different diseases as well. Okay. Actually, that brings up the at least the last question that I have on cards that was handed over to me finally. Maybe I have one more. Last but not least. Why are the doctors so reluctant to do a PET scan? Is it possible that a PET scan can reveal sarcoidosis better than blood tests and biopsies? That was a question that was asked to me in the past.
I'm retired, so I'm being bad. Anyway, yeah, the cost is one of the reasons why. Before, when I first started medicine, we could look at a chest X-ray because that's all we had. Later on, you had the CAT scan start coming along. You send them to another hospital to even get it because some of the hospitals didn't have CAT scan. But what I was taught when I grew up in medicine was you look for bilateral hyaloidinopathy on the chest X-ray or lymph nodes. and you were almost certainly sure that it was sarcoid if you also had a lymph node in the high right paratracheal region. So we had what we call the triad. The right paratracheal lymph node was enlarged, the lymph nodes were large in both right and left. And then there's not too many things that'll do that, except for sarcoid. There's some other things that'll do that. So those things help us out a little bit. So looking at the other tests and things that come along, so we look at, then you get to talk about the cost and the efficiency of doing some of the tests and things of that nature. And then you get a little bit better at making the diagnosis of at least suspecting the diagnosis of sarcoidosis, then proven by biopsy, obviously, would be the gold standard. I don't know if that answered the question or not, but.
Are you just saying the cost primarily is the reason?
The issue, so, in the States, there are guidelines mostly dictated by what Medicare says in terms of getting it authorized by either insurance, Medicare, name it. And the reasoning behind that is that there is not a lot of research that has shown that the PET-CT, even though I believe it's a great tool to help us mostly decide A, where to biopsy, and B, how active is the disease, there is not enough research that shows that repeating that down the road will tell you whether the disease is getting better or not. So if you go to any of the centers in Europe, the Netherlands, they do it more often, and they don't have a problem getting it done to the patients. Here, any of us, when we order a PET-CT for the particular diagnosis of sarcoidosis, it would not get authorized as yeah. And the reason behind it is there is not enough research backing that up, okay? The other thing I want to mention is it's a great test, but we always have to weigh the risk and the benefit for anything we're doing. So remember, every time that you go to the PET-CT, the more radiation you're getting. And radiation accumulates in your body, it doesn't go away. And the more CAT scans, X-rays, PET-CTs you get, that radiation stays with you and increases down the road the risks for any radiation-associated condition. Okay? So it's a great test. We are using it a lot for cardiac sarcoidosis because it's actually one of the, when you suspect cardiomyopathy, it's no-brainer. Insurance companies will approve that and it will go through. But for sarcoidosis itself has been a challenge here in the States. Now, WASOC, the American Association of Sarcoidosis, American Thoracic Society, and I understand American College of Chest Physicians have been working in trying to bring the evidence together and working towards doing guidelines so we can use better the PET-CT in sarcoidosis. I hope that answers your question.
Just wanted to know, I hear people talk about stages, stage this, stage 1. No one has ever come to me and told me I had stage 1 or stage this. What is the deal with that?
Yeah, they used to frustrate me to no end when they talked about the different stages. The stages is a very simple thing. When sarcoid was first out, they had different stages noted by the X-ray changes. Stage 1 was this, stage 2 was that, stage 3 was that, stage 4 was that. But it had nothing to do with significant other thing. Other than at stage 4, you had a lot of fibrosis and scarring in your body. Stage 1, I forgot now.
Just to reiterate, stage 1 for pulmonary sarcoidosis, stage 1 is for lymph nodes just in the lung, but nothing else. Stage 2 is lymph nodes plus infiltrates in the lung. Stage 3 is infiltrates in the lung, and stage 4 is more fibrosis.
You can't. What we didn't want people to do is to say, oh my God, I got stage 4, I got stage 3, that kind of thing like that. It's simply, now it may mean that you have that, but it does not necessarily mean that. So I used to try to teach my patients, don't learn the stages. You don't need to know that. This is just for us to pimp medical students and conferences and things of that nature. Now it's important to know that, don't get me wrong. But it's not that clinically relevant in one sense.
And there is no absolute evidence at all that someone who will have stage 1 will progress to stage 2 or 3 or 4. It's not like cancer. So there is no indication in that sense.
That was the point. It's not like you started with stage 1 and progressed to stage 4.
Okay.
Yeah, so
Okay.
it's not like cancer, you got stage 4 cancer,
Yeah,
you're in
yeah.
trouble.
Yeah,
So
right.
stage 4 sarcoid does not necessarily mean that.
Okay.
Okay, we know that patients with stage 4 tend to have a worse prognosis than patients with stage 1 because stage 4, the lung is more compromised, okay? But yeah,
It
it's
does
more
not
like an
progress.
academic exercise, and yeah, the whole point is not, 1 is not followed by 2, followed by 3, followed by
Okay.
So I'm glad you don't know your stage.
Yes.
Right. When I was practicing, I never would let my patients talk about staging.
Yeah.
Now,
Well,
we,
I think I found out
Right.
because you just explained the different stages, so I did find out what stage I was
I
in.
tried to leave that in the textbooks for my
Yeah.
Practice of self-deduction, awesome.
Yes.
I'll go on to the next question. Pain management, what is your opinion on medicinal plants if prescribed ones are not helping regarding CBD oils and edibles?
Well, I use a lot of CBD oil now. I'm older, and I just started using some till I finish, till I retire. I read the TV ads, I said, man, I've got aches and pains in my joint. So I was taking Motrin, and my stomach was hurting, and this, that, and that, so let me try some of this CBD stuff. And I tried it, and it worked. I don't smoke it anymore, I just got the rubs, I'm not, that's it, I'm not thinking about mouth. I rub it on my knee, and I said, I feel pretty good. But, you know, pain management in sarcoid was a problem for me, because I had a lot of patients who had biopsy-proven small fiber neuropathy, and had chronic pain, and this, that, and the other, in patients with sarcoid. So, you know, a lot of them had graduated to narcotic use. And I didn't like that, but there was nothing else that seemed to resolve their pain. Sent them to pain clinic, people, this, that, and the other, they didn't seem to work, put them on different medication. None of the medications that I use for treatment of sarcoid seemed to help the chronic pain. So, but finally we started using other things to help out. Get them off the narcotics, give them counseling and this, that, and other, and that seemed to be a much safer and better way to manage their chronic pain. Now, so I retired before the big CBD busted out. So people are hopeful we're using it. All I can say personally, I don't have small fiber neuropathy, but I got arthritic pain and it helps me. But I hope something like the CBD oil is helping a lot of the patients out there.
It's a great question. I think nobody can answer for sure what's the right answer. Particularly in sarcoidosis, there has been a huge interest. You go to any conference, everybody talks, saying that all their patients seem to be trying it. There is no evidence in terms of research that supports it. But I have few patients that have used it successfully. Few of them have used it unsuccessfully. So I don't think I would support it, but I will not tell you not to use it. I don't know what your thoughts are.
Certainly not inhale it into the lung, please.
Right.
So you don't want to add more fuel to the fire. And we are finding more and more cases with these kind of things causing harm in the lung if and when you inhale it. But I don't have enough evidence to support using this on a regular routine basis. If at all there are patients who are using pain medications, it's better, sir, that they see a pain specialist and make sure you have one person taking care of your pain schedule rather than having multiple different people taking care of your pain schedule. You have something to add?
Can I ask Dr. Copeland a question about, I want to ask you a question about feeling in your face. Do you have an issue with the nerves? Now, at one point, my gums would swell and my face would swell, and found out that I had sarcoidosis in the submandibular gland, in the saliva gland. So the gland was removed. And I had 4 sinus surgeries, and they told me that in the process of that, I might have nerve damage from those surgeries. So I don't have sensation in the left side of my face, and I was wondering if you had that problem.
No, I actually just had biopsies, just one lymph node that was in my neck, and they went behind my ear when went to Parodic to check it out and also take some of the scar tissue that they saw, but I didn't have anything. They were just kind of looking at it over the years because, I mean, you guys are fortunate to have physicians who focus on sarcoidosis, but in LA, like, everybody that would see me, it was kind of like I don't know, I felt like I was a science project sometimes, like so many people going in like, ooh, what's going on? So, but not really any answers until like when I really was sick. And also my sister helping out too, because she was asking questions because, you know, it affected her personally because I was going through it. But just over time, like I said, my face was swollen. If you go to my website or if you watch the episode, you'll see some of the pictures. But my face was like really large. And then it was hard, like it wasn't like it was just swollen and you could put your finger and press it in. It was hard as a rock. And it just went away over time. So I didn't have any surgery to remove anything because they didn't know what was going on, and I just continued to have blood tests and different tests done.
Actually, Addison had hair frauds, right? When you were first diagnosed and you had facial palsy. How did you, what was your experience?
Well, I had just had my son, Christopher, and I was ready for work. I was a sergeant on the police department, and I couldn't keep any water in my mouth. And my mother was a nurse, and I was like, well, Mama, I can't. And she looked at me, she said, well, half of your face is paralyzed. She says, you need to go to the doctor. I said, well, I gotta go to work. But I had the facial paralysis, I had almost lost my eyesight, and I had the fever, dry mouth, I had the nodules on my legs. But you know, I went to work, drove myself to the hospital, don't know how I did that because I couldn't see. But a young intern, he said, well, what's going on? I told him about the fever, he looked at my face, he says, oh my goodness. And I said, I can't hardly see you. He said, well, what else do you have? I said, well, I had the nodules, well, I had 3 kids, I didn't worry about taking my clothes off. He stood there and he was just looking. He says, I just read it in the book. So he knew just from class. So then when doctors come in with these little lights on, you know you're in trouble. But that facial paralysis had gone on for some time. But I just, you know, you never stop to say, okay, well, let me see. And that's why I tell everybody, don't let anything go on. If it goes on for 3 days, you need to be calling somebody. But that was, you know, it was just so, everything at once. And you don't feel well, but you don't know why you don't feel well. But yeah, that was an experience with that. But, oh, and one other thing, when you talk about first responders, when I was diagnosed on the police department, there was 5 of us all together, and all of us had it neuro. And at one point, there was like a RICO unit. We were all in that RICO unit together at the 9th precinct. Well, the 9th precinct has always been known to be on top of something, a paint factory, or old car dealership, something. But we were all there together. So there's something in the environment that will trigger this. And I still believe that all of us at that one point was exposed to it.
That's where I worked. I was a sergeant at number 9 for 18 years.
Along with what Allison has mentioned, with my mom having sarcoid, I grew up in Dearborn, and at night it was kind of a joke, oh, we're smelling the sulfurs from the factories. I lived on the east end, closer to the steel mills, the car factories, Ford Motor. We both worked at Hutzel Hospital about the same time. They were doing a lot of construction within the hospital, and they were just using clear plastic to separate the construction area from, and my mom and I worked on the same floor as this one huge construction site was going on, construction. And I was at Cleveland Clinic for the conference when Wausau was there about 5 years ago. And one of the doctors who spoke to us talked about a a contributing factor could be having coal furnaces. I used to play with the coal in our basement. Touched it, it was just, so I keep saying, you know, my mom and I know it does run in a lot of families, but because we were both in the same house for 17 years in East Dearborn and working at the same hospital on the same floor, there's just too many coincidences, you know, I just wonder, you know, were we both predisposed to it? Her doctor told me the day she was dying at Detroit hospital that I would never get it because I didn't smoke.
I don't want to endorse smoking, but there has been actually some reported cases where smokers don't usually get sarcoid for some or the other reason. But definitely, please don't go out and smoke. And same thing with hypersensitivity pneumonitis. I see Jenny in the audience here. Jenny, what was your experience like? How coming to a diagnosis of sarcoid?
Well, firstly, I have psoriasis. So, I had problems with my eyes. I had chronic bouts of uveitis. And so after I went in for my third bout, my eye doctor sent me to see a pulmonologist because he sensed that was a sign that I had sarc. Well, they didn't do any testing at that time, and so they didn't find it. Turn the clock back turn the clock forward about 3 years, and I had a colonoscopy, and I spiked in fever. I've been tired for about 7-8 months, and I was on several bouts of antibiotics because I had a sinus infection that wouldn't go away. Then I had an ear infection that didn't go away. And they kept switching me on to different antibiotics, and I turned out to be allergic to them. So then I decided, because I was losing weight, I was tired all the time, to go see a gastroenterologist. And so they did a colonoscopy. And the next day, my fever spiked at 102. So I went to the ER because my mother had a colonoscopy and put her in the hospital for 8 weeks in a coma. So I didn't mess with that. They did a CT on my abdomen, and that's when they spotted the sarcoidosis in my lungs. So after considerable thought, Dr. Sadiq referred me to Dr. Nair to see about it. And so he's done several tests. He did the CT over again, and then we decided to do a biopsy, and he confirmed it. And the biggest problem for me right now is when you're feeling great, you feel great. But when you get hit, like these last 5 days, I've had fevers, I've been spiking fevers, I've been tired, my eyes feel like ground glasses. So I got tired enough that I tried to take a prednisone, and that shot my blood sugar, which was 96, by the way, that morning before, up to 173. So I decided I don't want to do that ever again.
Thank you, Jenny, for sharing the story. But that's a problem that we come across with a lot of patients who have sarcoid in itself. It's like when to treat, how to treat, and how best to treat it. And it's always a double-edged sword, like what we were discussing earlier on. Are you going to be more affected from your symptoms from sarcoid, or are you going to be more affected from the treatment from sarcoid? And that has to be clearly weighed based on routine repeated testing, repeat imaging, pulmonary function test, and so on and on. Any closing remarks?
Since I've been around just about as long as anybody in the room, when I first first learned about sarcoid, the treatment was high-dose steroids, just about for everything that came up with sarcoid. You know, anywhere from 40 to 60 milligrams of prednisone a day. But throughout the years, I learned that I think I'm hurting people with this dose of steroids. Some other people around me started saying the same thing. In fact, one of I inherited the sarcoid clinic from another doctor who was at Henry Ford that went on to something else. He was always starting out with high, not that high, but at least 40 milligrams of prednisone a day. So he did it. I should probably do the same thing too. And after doing that for a while, because I started seeing more patients with sarcoid, I said, this is not that effective and it's causing more problems. So I started dropping the doses down to half of that, getting them down pretty, once the symptoms were heading to control, I would reduce it down to maybe 5 or 10 and see how that worked. If they started having more symptoms, I would add a few milligrams of methotrexate and see how that worked for a while. And most of the time, we did pretty good with low-dose steroids, low-dose methotrexate, and a lot of times that took care of things. If I had to add something else, sometimes I would add something else, but those were my two big guns. But I learned to avoid steroidosis. All that did was make people swell up, diabetes, cataracts in the eyes, and all this other kind of stuff. If we had to, the only time I would use high-dose steroids with neurosarcoidosis. And then I would use occasionally 60 milligrams, 40 milligrams until they were controlled, then cut that down to something else and finally work it out from there. I had one lady with severe neurosarcoid. We got her controlled at 60 milligrams of prednisone a day for a while. Boy, she blew up, but at least controlled the neurosarcoid. Started backing off, got it down to 20 or 30, and then she started getting sicker again. We started using other adjunctive therapies, which seemed to have controlled her. And by that time, I was retired. So you see one of these guys now.
Are there any other questions from the audience?
I actually have a friend in Las Vegas that has this, and I was just wondering if you guys could recommend somebody that's out in Las Vegas or even the LA area that I can send her to, colleague, associate.
Sorry, I don't think I know anybody in that area that I could.
Would the directory from Wausau or?
Yes, I would recommend, that's going to say, recommend the Wausau directory, because they usually have.
FSR should have the directory of the recommendation. FSR should have the FSR or stopsarcoidosis.org. There's a list of clinics that are recognized by Wausau.
What is FSR for those who?
Foundation for Sarcoidosis Research.
Stop sarcoidosis.
Usually, if it's not explicit in the website, sometimes interstitial lung disease clinics will have the most expertise in sarcoidosis.
Any other questions from the audience?
Thank you.
Okay. If not, I would like to thank all the panelists sitting here for contributing their time, coming up here. I would like to thank Allison and the Sarcoidosis Foundation. And last but not least, for all of you to come here and ask your questions. Thank you. Uh-oh. We go back. We will begin again.
Okay, so my brother has sarcoidosis. It was diagnosed in the early 90s. Also, he was diagnosed with chronic fatigue syndrome, but he's had the, what's the test that you check the nerves for the sarcoidosis, the pain? You just mentioned it.
The biopsy?
Yeah, but what's the?
Small fiber neuropathy?
Yeah, okay, so he's had that, that came up negative. But he has this horrible post-exertional malaise. He can do anything. He can mow the lawn and then he'll be in bed for 3 or 4 days. And is how, you know, I mean, there's any disease, any person can have a host of illnesses, comorbidities. I think what I'm hearing from all these people here is that they want to know what the association of sarcoidosis is with other illnesses, right? I mean, you can have congestive heart failure, diabetes, and et cetera, but it's not necessarily related. And I'm hearing that a lot of people are just sort of wanting to know what the association is between their comorbidities and sarcoidosis. And basically what you're saying is that you don't know, is that correct?
Correct.
So where are the epidemiological studies being done? And are they being done? Is that the Sarcoidosis Research Foundation or?
So there are many research endeavors right now for sarcoidosis.
Right.
One of them is a registry that you mentioned.
Right. But as far as epidemiological studies, taking the data from this woman here in her neighborhood, taking the data from Allison's precinct, taking the data from all these different things, having physicians who have patients with sarcoidosis, I'm a registered nurse by the way, having that physician register the patient in that registry as being part of that patient's care, as being, if internal medicine physicians have care managers, which are registered nurses who manage the care of those patients, a little bit more deeply, a little bit more I'll say holistic for lack of a better word. But anyway, make that part of your treatment plan that you register your patient within that system.
That system is basically driven by the patient, so the patient has to register him or herself.
That's fine, but we can change that. We can have it driven by physicians so that we can get that data.
We can give all the information,
Yeah.
and that's what we try to do in our clinic, but it's up to the patient to go to that registry and get their data on the registry.
Well, people with sarcoidosis don't always feel good, so.
I understand.
All right.
I wish I was the one who
What would be the
decided.
obstacle? What would be the
We
obstacle?
legally cannot register for a patient.
So
I would love to, but we can't do that.
It depends on who is doing the research. So in this particular instance that you're mentioning, this is the Foundation of Sarcoidosis Research. We did not design it the way they are doing it, okay? So for anybody to be able to get the data for any patient, for a registry or any simple study, we will need to obtain their consent and go through the IRB process, right? So there have been many barriers for epidemiological research in sarcoidosis. And luckily, I think WASOC and ASOC have been working in the last 10 years to try to get more funding from NIH towards that epidemiological approach. But we're still far from getting what we need in terms of research. Honestly, I don't know what else to answer. I truly wish we had these clusters research to know what exposure do they have, what is the soil there. But it's just, there has not been from the NIH, for instance, there has not been an intention to fund sarcoidosis research until recently. The same with pharmaceutical companies. It's not a common condition, so they don't see, unfortunately, they don't see down the road that any particular medication targeted for sarcoid will give them a lot of revenue. So those have been the barriers, but that is changing. More doctors are interested in sarcoidosis. More basic science researchers are getting NIH funding to try to find the cause of sarcoidosis. There is more, right now there is more genetic research. Every time you go to a conference on sarcoidosis, they're trying to find the genes that are mostly associated with sarcoidosis.
Yeah, I mean, there's different things that people are looking at, that's true. But there's lots of epidemiological studies going on all over the world where the patient does not have to be involved in giving that information. The information is actually garnered from medical records.
I don't disagree with you.
Yeah,
I don't disagree with you on that one, but that's the best way we have right now.
Okay,
It's not
right.
perfect.
So as far as small fiber neuropathy then, and the symptoms, the associated symptoms with that, how common is that with sarcoidosis? Not just how common is it, but how do you draw the line between, yes, this is coming from chronic fatigue, or yes, this is chronic small fiber neuropathy, aside from having that biopsy done? Do you know? Does that make sense?
So, yeah, so there is no test for chronic fatigue syndrome. There are diagnostic criteria. And and we know it's up to 10% of the patients with sarcoidosis may have both of them. We know treatment for the inflammation in sarcoidosis does not necessarily improve the neuropathy or the chronic fatigue syndrome. And the sarcoidosis community knows that those two are the most difficult conditions to treat nowadays in patients with sarcoidosis because, again, a lot of research they have tried IV immunoglobulin, they have tried rituximab, they have tried Remicade towards those, and nothing has been shown of any benefit.
I know the precursor to this conference was about staying out of the hospital. So, you know, you might get sniffles, you got sarcoid, you're like, oh Lord, do I have fluids in my lungs? How do you know when it is time to go to the hospital and when it's just time to take some Sudafed?
That's a toughest question.
Okay.
All right, because I mean, any symptom that would warrant potentially, or any symptoms that's not getting better, anything out of ordinary. So you're coughing daily, but now you're coughing more yellow-green phlegm. You always had some sort of fatigue, but now you're having like high-grade fever. You always had some sort of mild chest pain, now you're having severe chest pain.
Okay. So it's monitoring yourself.
It's daily monitoring of your own self and taking care of yourself after taking all the necessary precautions, including the vaccinations that I mentioned, and avoiding risk factors like smoking and being around people who potentially have those illnesses when you're on immunosuppressive medication. So if you have any trigger that's not not your ordinary symptoms, and you're having worse symptoms on a couple of days at a stretch, I do recommend that you seek medical attention. I have a couple of patients in the audience already. The system has gone forward much ways. Like it's not like you have to call up the doctor and wait for him or her to call back. The doctors tend not just work in clinics; they have other things to do too. They do research, they do work in the ICUs, in the consult sites and stuff like that. So it's not easy to get hold of a doctor. And so most places where you have this kind of expertise, you all have people like Heather, who is the nurse navigator for the program. So you can leave a message and have her or him return the phone call back to you and find out what is going on. If there is any other test that needs to be done, additionally, should we do a chest x-ray, make sure there is no pneumonia going on there. Those kind of things could be done by the nurse navigator. In fact, most of the electronic health records nowadays, you can directly communicate with your doctor and leave a message with the doctor so he or she can actually see that. So I encourage you, like if things are not straightforward, and you have a new symptom that's not been there, and it's going on, seek medical counseling.
Thank you.
All right, last question, and we have to end. I was gonna say, since I'm retired.
Listen, I hired Detroit Police Sergeant, but I was diagnosed for Allison. And the department tried to make me retire because the police did not know what to do with someone with sarcoid. They tried to make me retire, but I fought them for 3 years and I was able to get my 25-year retirement. But I know there are a lot of people, like she says, she's still working, but they try to get rid of you. I know other people that have the disease that have jobs and other things, and they don't want you to work. The police department now, if you have sarcoid, they will make you take a non-duty disability. If you have a non-duty, because I was long before she was, and I was able to get my full pension. But anybody now with sarcoid, the police department will put you out because they don't know what to do with it. because and that's hard. So I don't know what other folks are doing.
They don't
I
want
just,
you to be sedentary, you know, they don't want you to sit around, you know, keep you straight. Working, but.
This isn't the first conference we've been to. And my wife talked about going to a conference at Cleveland Clinic years ago. And it was really interesting because on one Florida hospital, we were having a conference of people that had sarcoidosis. Below us were doctors from all over the world that were doing research on sarcoid. So we had a few doctors come in. One of the doctors was from the Netherlands. I remember a young woman, a young doctor out in Colorado, that was very passionate. The thing is that you mentioned, doctor, is sarcoid isn't a well-known disease, and there isn't a lot of money for research. There are some very, very passionate researchers out there worldwide, but there just isn't the money for the research. And we come to these conferences, and now that I've been to a lot of them, I understand that there's no cure. We don't know where it comes from for sure. We just, people have it. And as a caregiver, we work around it. Like you say, how do you know? I know when she needs to go to the hospital because I've seen it so much. I'll say, okay, this is it, let's go, before it gets any worse. But that's what's frustrating to everybody is we don't know things. It's just frustrating, that's all.
And honestly, we share the frustration. We do share the frustration.
All right, one more frustration.
Okay, so I was diagnosed with neurosarcoidosis, and the way I feel right now, it's gone to a whole lot of different places. I finally had a PET scan, and it's showing that I have uptake in the osseous, which means bone parts. And I need to know, does that mean that I have sarcoidosis in my bones? And what does that mean?
So the question was, she had neurosarcoidosis, but had just recently a test that showed potentially involvement of the bone. Could this mean that this is also involved in the bone also?
So what was the PET-CT performed, if you don't mind me asking?
Pardon me, what was the question?
Why was the PET-CT performed?
Because I'm having symptoms everywhere, okay? With the neurosarcoidosis, I have bone pain and cracking and everything in every joint. And when the PET scan does show an uptake in those areas, and my question is, I don't know.
It's certainly possible. The PET-CT is not specific to detect sarcoidosis. So,
in other words, let me rephrase the question for her. For Charlotte, is there any additional testing that needs to be done if there is a PET scan that's showing like potential involvement of the bone?
Yeah, there needs to be additional testing. It can be sarcoidosis, but it can be other conditions that may turn the PET-CT positive. So it is likely, depending on what your doctor wants to do, it is likely, or if you're in my office, probably we will need to offer a biopsy of that particular place that is having uptake.
That was the original reason too, why the PET scan was taken to find an optimal area for a biopsy, because I do have some other issues going on, and we needed to find something that would maybe correlate the two. The biopsy to confirm sarcoidosis and concern the muscle wasting that I'm having. That I don't know if that's what you were talking about, the inflammation in the bones, if that could be a manifestation of sarcoidosis, or is that something different? That's my question.
I concur with that statement. You definitely need to have a biopsy done. I would strongly recommend that.
So to reiterate, yes. The answer is we have to find a source and find out if there are granulomas and inflammation at that particular source to confirm. But just to reiterate the frustration in the room, I do mostly see patients with pulmonary fibrosis, which includes patients who have sarcoidosis too. And there are types of pulmonary fibrosis, especially idiopathic pulmonary fibrosis, which are which has a prognosis even much worse than sarcoidosis in terms of mortality. Someone who's
diagnosed with IPF tends to live out like 3.5 to 5 years post-diagnosis and has worse prognosis than like many other breast cancers or colon cancer and other diseases like that. And early 1990s to 2000, people tried to do a lot of research and try and come up with answers. Up until 2005, there were like hardly like 4 or 5, a handful of like good research studies that were done. But since 2005, with much more interest in the disease process and people recognize that it's a much deadly disease to have, the amount of research just went up multifold. We are talking about from 5 or 8 to around like 400 to 500 different types of randomized controlled trials trying out different medications. And by 2011, we had some signals, and by 2014, we had 2 approved drugs that were potentially able to slow progression of disease. And good news is, now in 2019, we know those medications are helpful with certain type of, with mortality too. So the interest that we have, and people who are interested like at Cleveland or Mayo or here or other places, I have a clinical trial coming up pretty soon. So I encourage you to actually go up and join those trials. Be a participant for the trials. It's only because of you guys that we are able to find out what is causing and how best we can treat that. Positive news on a good side, even though that we didn't have that many patients in that trial with sarcoid, fibrotic lung disease as such, New England Journal just published a test result on one of the antifibrotics, and that has shown to slow progression of disease in a conglomerate of patients with fibrotic lung disease, including sarcoid. So there is treatment coming up. It's just that we have to put ourselves out there, register in the registries, and also ask your doctor when you go up and meet with your doctor, can I be a participant for any type of research? And that is what we need. We need that close coordination and partnership with the patient and the physicians to come up with the appropriate diagnosis and a cure for this deadly disease. Okay, with that I would like to conclude, and maybe I'll hand over the mic to Allison.
Thank you so very much. I want to thank our panelists. It was wonderful sharing of information. Dr. Nair, thank you. Love it. Okay, I want to say thank you for everyone to come. We just have some final words to say. Join the clinical trial. I did. That's how I really learned about the Remicade that I'm on. Sign up. It's not scary. They tell you everything you need to do. We'll upload the links from Heather's paperwork onto our website, where you can go onto there. It's caringhandsofmi.org. You can also go on there and send me messages. Everybody has my cell phone. You can give me a call. But I want to say, you know, when you walk away from this, that you are more empowered to make some good decisions for yourself. You know what questions to ask your doctors. You know what you may or may not want to do. So just be encouraged with that. Now, for our panelists, we gave you a little token of love. When you're sitting at your desk thinking about us reading our charts, you'll have something to keep you occupied. So thank you so much. It's just a token of love that we're giving to you. I want to thank the Caring Hands staff for your hands. You all are awesome. Devin, thank you so much with 11 Cloud Marketing. Love you. You brought some new platforms into my life. Everyone will see me on Instagram Live. That's my new hangout now. So have a wonderful rest of your day. If you have any additional questions, you can message me and I'll send it over. But if you're a Beaumont patient, take care of your My Chart, because these doctors and nurses respond immediately. So make sure you have open communication with your medical staff. Okay, so have a great rest of your day. Thank you so much. Okay, we got a couple more photo shoots.
Oh yeah, you can hit into YouTube Live.
Oh, okay.